It's lively. Okay. All right. Shh. Ruth's trick works every single time. All right. First of all, apologies for the last minute change of venue, but it was this or listen to a fire alarm go off throughout the entire seminar, which seems suboptimal. So we changed venue. I'm happy to welcome everyone to the 2024 Hutzler-Rives lecture. The Sheila Hutzler-Rives Memorial Lecture is named after the daughter of Eleanor Ellie Trowbridge, who was a member of the Berman Institute of Bioethics Board and served in various other capacities within our university community. Ellie's daughter, Sheila Hutzler-Rives, succumbed to breast cancer in 1988, and up to her own passing in 2007, Ellie was a firm advocate and supporter of palliative care programs at Johns Hopkins and beyond. We honor her memory and that of her daughter with a lecture related to longstanding and/or emerging ethics issues broadly related to palliative care. And I'm delighted that Dr. Joan Teno is serving as the Hutzler-Rives lecturer this year. Dr. Teno is a health services researcher with over 25 years of experience conducting research on hospice care in the US. She's a board certified internist with added qualifications in geriatrics, hospice, and palliative medicine. She's currently an investigator on the CMS contract on creating the Consumer Assessment of Healthcare Providers and Systems Hospice Survey, the VBID evaluation of the hospice carve into Medicare Advantage, and past recipient of a Robert Wood Johnson Foundation Health Policy Investigator Award. Dr. Teno was part of the study panel of the 2014 IOM report on reforming how we care for seriously ill and dying persons in America. And in recognition of her research that resulted in over 300 publications, focusing on hospice, quality of care, and end-of-life care for persons with advanced dementia, she's the 2023 AAHPM Lifetime Achievement Award winner. Please join me in welcoming Dr. Teno.
Thank you very much. Really appreciate the opportunity. Okay, so I do read the Wall Street Journal. I also read the New York Times to balance things out here. Technically these days, I'm doing what's called a flex-tirement. I didn't realize that until I read the Marketplace about several months ago. Basically, the argument is that with all us boomers retiring at once after COVID, they were causing such a brain drain that they want some of us to come back and work part-time. And that's exactly what happened to me. I decided in 2022 to not write another NIH grant, which was a very happy day. And I point out to my former project officer, when I stopped writing NIH grants, I published 45 articles because I could do something else besides writing NIH grants to keep myself funded. But I was very fortunate to join the RAND Corporation, who I've been working with on multiple CMS contracts over the last 15 years as an adjunct staff. And because of that, I have to tell you that anything I say today has no relationship to any policy of the Department of Health and Human Services. If anything, they'll probably want to disown me and not use anything I do say, because sometimes they think I'm a pain in the ass. So how many of you have been down to DC to DHSS, the main office? It's one of the most impressive things. I've been fortunate to be there multiple times. Is this quotation by Hubert Humphrey. And he said, the moral test of a government is how that government treats those that are in the dawn of life, the children, the twilight of life, the elderly, and the shadows of life, the sick, the needy, and the handicapped. And I find that really apropos, because what I'm going to point out today is I think we've gone down the wrong pathway on how we're measuring quality. So here are the points. We ration care. We don't ration care by explicit criteria, but through alternative payment models with the stated goal of constraining cost and quote unquote preserving or improving the quality of care. So the old equation that value is cost plus quality. As we conceptualized, an important safeguard in that was quality measurement through CMS Compare websites to provide transparency and to guide public choice. And I will tell you, I turned 65 2 years ago, and I had a public choice to make about Medicare. That in itself was a very interesting navigation of the Care Compare website. I, over the last 15 years, have been involved in the CAPS system, and specifically the research that I did informed the development of the bereaved family survey called the CAPS Hospice Survey. And previously we had called it the Family Evaluation of Hospice Care, which was part of a voluntary repository with the National Hospice and Palliative Care Organization. We managed to get about 1,800 hospices doing it and, generated reports. We literally handed that over to the government. They made some changes, and now I think it's been ongoing since 2016. And so I've been working with that team going back to 2012. It's been a lesson in becoming psychometrics. And one of the key aspects of this whole process you go through to say something can go on the Compare website is this notion of inter-unit reliability. Okay, before you glaze over, what happens at inter-unit reliability, that implementation of that criteria has an impact on how we're measuring the quality of care, which has an impact on what we value and how organizations respond. And that's one of the things I want to talk to you about today. So as I was saying, I was delighted to do this talk because it gave me a deadline. And, in a flex-retirement, we don't really exist in deadlines. But I decided to take this talk and boil it down to 1,000 words and write a JAMA viewpoint. And it's been under review for 2 weeks. So, the success rate viewpoints is pretty low, but I feel that it will probably have a home somewhere. Maybe, I've published a significant amount of viewpoints in JAMA Health Forum, but I decided to just, get another rejection letter to make sure that I was not forgetting the fun of rejection letters. The title is Quality Measurement for the Seriously Ill, the Denominator Problem. You could also substitute quality measurement for disadvantaged populations, the denominator problem. You could substitute quality measurement for rural health, the denominator problem. Choose your favorite, thing to substitute. So specifically, I want to talk about what are the challenges? How does this impact something that I've obsessed about for the last 35 years of my life, hospice and MA programs. MA programs is a new add-on. And then I'm not only going to criticize, but I'm also going to offer some potential solutions. Now, I haven't worked out the full, how to implement these potential solutions, but I wanted to get a dialogue with doing this. Okay, rationing. Okay, we're all be wary of the hyperbole that we have this onset of gray hair, retired college professors who in their first year of retirement have used a lot of healthcare resources getting cataracts done. And I tease my CMS colleagues to the nth degree by saying, thank you for paying for it. I absolutely waited, so I didn't have that $6,000 copay and waited for Medicare to pay for it. You can see that 12% of the population accounts for more than 34% of the national health care expenditures. I think you have to be very careful about these things about high cost. And there's two things I want to point out. One, a lot of high cost is really custodial care. It's nursing home care. It's for people who are ADL impaired, cognitively impaired, and a lot of this is really Medicaid outlay, okay? And unless you're going to make some radical change in the system, I don't think you're going to be saving a lot of money with that. The other thing is, when we talk about the high cost, we ignore the work of Ann Skatosky, okay? So this is really like flashback. Who in the heck is Ann Skatosky? She wrote a really important paper about 40 years ago that looked at the data and said, how we spend, what's this money for cost at the end of life going to? And a lot of it is not going towards ICU care. It's going through, you know, custodial care. It's going for, you know, hospitalizations when someone who was previously healthy. So, you know, the fact that there's a pot of gold to be found in, you know, high cost care, I'm a little bit doubtful for. You know, the other thing I would caution is a review of whether there's going to be reduction in the benefits in Medicare or in Social Security. I think, you know, I love they state all these things as their ironclad flags, but I noticed they also change year by year depending on how the economy does. And none of this is presented with any confidence intervals or any kind of sensitivity analysis. So, you know, it makes great hyperbole. So, but I don't think the system is going to totally go broke, but it may change. So my introduction to this whole debate was in the 80s. You know how life can be happenstance, okay? In the 80s, I did a internship at Brown University, and the National Science Foundation paid for a philosopher to round in the ICU with those would-be young whippersnappers. I was one of them. So I spent my entire summer, my internship, rounding with Dan Brock. And, you know, talk about life, you know, Dan and I would have these wonderful discussions about withdrawing ventilators, food and hydration, and ended up just being a lifelong friend. And, you know, for those of you who don't know, Dan Brock served on the President's Commission of Biomedical Ethics, was really one of, I think, you know, just the greats in terms of biomedical ethics and just a wonderful human being. Dan brought Dan Callahan to speak to us about Setting Limits, which was his current book was out there. Setting Limits, and this is my copy of Setting Limits, which I found in a moving box because I moved 4 years ago, went down to the cellar, dug it out, had all these underlining on it. And, you know, there was this furious debate about whether we should make some explicit decisions about healthcare rationing. That, you know, whether, you know, we should take the Sikh Emmanuel approach, you know, at 75 or some age cutoff, you no longer get access to ICU care, or you know, no longer get access to this. And, you know, Dan was really trying to explore what we should value in terms of an aging society. And, you know, some of those quotations I think is pretty readable for you there. But as a postscript, Dan actually died short of his 89th year with recurrent VTAC, and he had a medical bill of $80,000 for a pacemaker insertion. So, you know, I think we had this furious debate, and one of the outcomes of the furious debate led into Obamacare. So for those of us who used to hang out in the halls of the Hart Building, I can't tell you how many times I was told you cannot mention the word advance directive. It became a dirty word. It became like, you know, you can't talk about this. And a lot of this was from Sarah Palin and those wonderful years when, you know, they assumed everything that was going to come under the ACA and paying doctors to talk to their patient about their goals and values was essentially going to be killing people, targeting only those people who were disabled, those people who were disadvantaged, and led to a story of the cartoons. Do we ration care? Absolutely. Scarce organs, we ration care. Part of what I'm very concerned about is we're rationing care based on affordability. Okay. I perfectly honest, didn't want to shell out a copayment, of $6,000 for my insurance. As I was transitioning from, there's several months before I retired until I got onto Medicare. I wasn't going to pay $6,000 for cataract surgery. So instead I was driving at the risk of drivers in Rhode Island. Fortunately, I cut out nighttime driving. But, we do ration care based on affordability. It's an everyday decision, okay? Look at the advertisements. It's amazing to me, 3 months prior to my birthday, I received 57 pieces of mail from various Medicare Advantage programs, all offering me 0 premiums, dental coverage, eyeglass coverage, all these wonderful things. Oh, silver sneakers, you name it, anything to induce me to sign up into an MA program. What they don't talk about is the out-of-pocket costs, the narrow networks, the ghost networks. Believe me, those networks exist in Oregon. I've seen them. And the fact that, a lot of your decisions are going to be based on how they use that money. So I think in the way that we've said, all right, we're going to have a private organization make decisions about denials, prior authorization. Essentially, we're rationing care based on the ability to afford care, okay? And I'll tell you a little story when we come a little bit later on. I became very concerned when I started looking into Medicare Advantage plans and how the quality are measured, because typically I lived in this world of hospice. And, as I was told time and time again, you focus on such a small percentage of the healthcare utilization. Why can't you focus on long-term care and be like the rest of us in the Center for Gerontology and Healthcare Research? But this is what I've been passionate about. Somehow I managed to keep funding on doing it. And, today I'm still continuing to do it. So here's a typical advertisement for MA, okay? Nowhere present in this advertisement is anything about narrow networks, co-payments, annual deductible, or affordability. So this is actually from Rhode Island, and this is, typical of the mailers that I received of this. Just a little history. So out of the ACA, there came 2 organizations, PCORI and CMMI. I am terrible on CMS acronyms. Now, mainly, I've worked so long in part of CMS project that every time I turn around, they have an acronym and they've changed the acronym. There used to be things called focused medical reviews in the hospice world. It's now TEPS, targeted enforcement, and planning and education. I just, at this age, I just can't keep up with all these changing acronyms. So out of the time when they created PCORI and CMMI, they are very clear in that anything coming out of these organizations would do with anything on coverage decisions. They created essentially a firewall between that. But what CMMI did do is they did create this notion of alternative payment models, okay? And I have some concerns that so far, really, there's maybe a few payment models that have really worked. I've been involved in 2 evaluations of payment models that haven't worked, so CMMI has had somewhat of a dubious record in terms of these alternative payment models. They started out with this notion of constraining cost and improving quality or maintaining the same level of quality. Over time, they've evolved it to the 2024 goals of improving patient care, lowering the growth of healthcare costs, better align payment to promote person-centered care. But if you look at ACOs, accountable care organizations, this is how they get paid. They get paid for constraining cost and maintaining or keeping the same quality based on a set of quality measures that are specified through a MUC process. Again, another wonderful CMS acronym, and I think sometime they're going to have to change the word MUC because it is somewhat of a mucky process to go through. So let's talk about MA plans. So when I was an intern, there was something before Medicare Advantage, it was called Health Maintenance Organization. And one of my co-intern's brother, who's a psychiatrist, got sued because in their health maintenance organization, they said anybody who's depressed could have 7 visits, but no more than 7 visits. And unfortunately, as everybody would predict, someone committed suicide and ended up suing them, okay? We have not learned from that history. Medicare Advantage plans, now that they've been rebanded, have 31 million people, okay? Nearly 1/2 of the US Medicare population. In 10 states, more than 50% of Medicare decedents are on an MA plan, okay? The payment, I don't know if I did that. The payment is based on a payment per month or PPM, and an incentive is based on quality bonus plan or the QBP. And the payment per month is based on these measures of disease severity. Now, all they've had to do any of this work for measures of disease severity is what a doctor places on a bill, okay? And part of the problem with that is coding. So what did MA programs do? They went out and hired nurse practitioners to make home visits. And essentially what they did during those home visits was find medical diagnoses and add them to the chart. And it turns out when you add those charts, you can result in a substantial uptake in the amount of money you receive. So an example that I have there is with diabetes. If you add a vascular code, it now makes it complicated diabetes, and you increase your payment by 45%, okay? Initially, only 1% of the bills were audited, okay? They recently increased them up to 5%, and then Humana is now suing the government over the audit of 5% of the bills. But upcoding there's been multiple articles, a lot of them from my colleagues at Brown about the problem. The other thing to do, so one of the things I did really quickly, I was just browsing the New York Times, and Sigma, there's an article in the New York Times about a physician who works at Sigma, where they take the physician, there's 70 reviewers for medical necessity, and the way they do it is they have a nurse review the case. These nurses are located in the Philippines, and they send them to the medical director, and the medical director is constantly being harangued on how quickly they make a decision. And about half these cases, they make a decision based on a computer algorithm, okay, which almost just results in an automatic denial. So OIG did a report and found that 13%, maybe I'll look over here. 13% Medicare coverage rules and 18% of the payment denials should have been covered by Medicare coverage. So these denials are a real problem and a real concern. I think I've already mentioned that narrow provider networks, prior authorization, copay, and out-of-pockets are really a huge concern. Now, what's even more concern, so while my focus is really on the seriously ill, I think a lot of people should be very concerned by the fact that dual eligibles are really increasingly being covered by MA programs in special needs plans and other forms and formula, so that you really have a growing disadvantaged population covered under this payment mechanism. You know, and I think it would be okay if we had the proper safeguards in place, but I don't think we do. So how do we measure quality in the Medicare Advantage plan. So another acronym, HEDIS, spelled it out for you. Basically, it's minimally processed measures, again, because that's what we're able to do. We're able to bill and look at billing data. It's immunization, screening, follow-up for ER for persons with multiple chronic diseases. It does include rehospitalizations. There is the CAHPS, the Consumer Assessment of Health Plan Surveys, which is now an entire family of surveys. They have one for virtually every silo of the healthcare system, ER, hospital. They have one for doctors overall, one for MA programs, one for ACOs. Then there is the health outcome surveys. Health outcome survey actually had a measure I thought was really important. It was 2 measures of functional outcomes where they measure the change over time, but that, which was originally publicly reported prior to COVID, still remains not publicly reported because of COVID-19. And, you know, there is 3 HEDIS effective measures from the Health Outcome Survey, monitoring physical activity, bladder control, and falls. They take all these measures and do a wonderful statistical analysis and put them into 5-star ratings. And if you're a 4 or 5-star, you can submit at a higher benchmark and get paid more money per member per month, and you can get a bonus for quality. Well, the bonuses have now gotten up to $12.8 billion. Research to date does not suggest there is evidence that QBB has improved the quality of care, which is a huge concern. Okay. So one of the things I've been doing as part of my flex-tirement, and actually started prior to my flex-tirement, is I got the opportunity to write for JAMA Health Forum as a contributing viewpoint writer, and it's usually a 3-year cycle. So I did, you know, 3 essays 9 times over the past 3 years, and all of them all focused on economics and end-of-life care and on hospice. It was a really fun exercise to do, because I typically would write a scientific article where it's just the facts and nothing but the facts. And, you know, I think I've gotten threatened to death for once in an article. I tried to introduce a new word into JAMA, and the editor called me up and yelled at me for saying, "You cannot do that." But a lot of times I've gotten the comments, "No, do not editorialize during your this is, you know, if you want to write an editorial, we can give you opportunities for that, but you can't do this in a science article." So these have been sort of a fun thing. And what I've tried to do with these is I tried to make it very accessible to a lay audience. Okay. My target for this was not the audience of JAMA, but really how things get done in Congress these days is staffers. Okay. Legislative assistants. And so I would, you know, routinely email them and be glad to speak with them and say, you know, 23-year-olds or 24-year-olds or under 30 who have no understanding of hospice or any of these things. I would gladly sit down and spend hours with them trying to explain to them what this is all about and why this is just not, you know, the complexity of caring for these people. So I tried to do very tongue-in-cheek things. The Lake Wobegon, this is actually, there's some of us who remember Garrison Keillor, some of us probably won't, but he had this wonderful thing on NPR, which basically talked about Lake Wobegon, which is an imaginary city in Wisconsin or Minnesota, I could be wrong. But the thing is, everybody was excellent. All the people were wonderful. And this is what happened with the QBP. So originally, only about 28% of the QBP rankings were 4 or 5-star programs. But then CMS allowed this process of consolidation, okay? And this took me for a while to wrap my mind around this. There's a parent company, okay? There's a contract, and then there's a plan. I, as a Medicare beneficiary, choose into a plan. The parent company sells a contract and bids on a contract. But a contract is made of multiple plans. Okay? Are you still with me? So what happened was CMS allowed the parent companies to consolidate plans into contracts. Okay, and all of a sudden, 83% of MA programs were now 4 or 5 stars. Okay, it's gone down a little bit. It's gone down to 73%. But I would argue that, you know, what happened was this very weird thing. Okay, so I started reading about this and then thinking about, you know, being part of the VVID carve-in, where hospice would be carved into Medicare Advantage program. I got very concerned. And so I rounded up all my friends who are health economists and one of my favorite mentees and said, we need to write a piece for New England Journal of Medicine. Okay. Dave Grabowski is a wonderful health economist who I've known for a long time. And so we wrote this piece on the role of Medicare Advantage and seriously ill. Okay. And Dave, after we got this piece in the publication, called me up and said, so what MA plan did you go with? And I was like, nope. Because, you know, when I looked at the data on Compare website, there were MA plans that I would choose from, and their quality measures were based on 7 states that were not contiguous states, you know, and so that would really tell me nothing about the quality. And, you know, I am your typical Rhode Islander. I live 60 minutes from Boston. I get medical care from Boston if I had a serious illness, you know, I did not want to give that up. So the concerns with the MAQBP, first of all, they allowed this practice of consolidation, and all of a sudden, everybody became an above average MA program. Okay, this was not an improvement in quality. Okay. Contract consolidation was responsible for about 37% of Medicare beneficiaries being consolidated into 4 or 5 star MA contracts. So these were previously people in very bad plans or, you know, bad contracts that they consolidated it. You know, I think it's always important to remember that there's 4 big players here. And these 4 big players are around 60% of the MA market here. So they really determine what happens. Okay. And this is just basically the Dave Grabowski story. I did not go with an MA plan. How many of you know who Jack Winberg is? Okay. So Jack Winberg was an amazing guy who I had a chance to work with. He's the guy who founded the Dartmouth Atlas of Healthcare. Okay. And the only reason I tell this story is, you know what, as a clinician, here's really what the important value you bring is. Okay. And this is his story of the value, except as a parent. So he lived in 2 locations around Hanover, New Hampshire, or Dartmouth College. And he found out that, you know, there's these varying rates in Waterbury Center versus Stowe, where he lived, on whether you got a tonsillectomy or not. Okay, 20% versus 80%. And that led him to downloading a lot of CMS data and looking at this whole notion of geographic variation. Okay, so I think for those of you who are clinicians, it's really important to take something that looks weird to you in your own practice and test it and examine it and ask questions about it. Those are some of the best things. To give you another insight, Susan Mitchell and I have written maybe 35 articles on feeding tubes. And the reason I started down this journey was in my first year being at GW, we had a patient who followed her wishes and did not put in a feeding tube, and she died 52 pounds. And I filled out the death certificate and said that the person died of dementia from severe dysphagia. And the funeral home gave me a hard time. And so that led to Susan Mitchell and I having I had a Coke, she had scotch, and we decided someone's got to do something about feeding tubes and dementia. And so that led to a lot of publications. So I think, my advice to you is find things that drive you nuts and do the right thing. Okay, so the other big concern is the duals, okay? 30% of the dual eligibles are now enrolled in a Medicare Advantage plan, and that's gone up rapidly over the last 6 years. And 19% who are not in these special dual eligible programs were in another type of Medicare Advantage plan. We're writing a paper on ACOs and long-term nursing home residents. And this is what really blew my mind. 20% of people who meet the criteria of being a long-term nursing home decedent were in an ACO. But from an ACO's perspective, that population only represented 0.2% of the ACO. Now there was variation. It went, the outlier was 8% of their population. But that just got me thinking, it's got to be hard for these ACOs when they have such a small number of people who meet this criteria, which are already, they're very complex and already very difficult to, so who are they going to spend money on? The average mass people or those people with end-stage dementia who are dying? So hang with me, okay? So in this process, when you go to propose a quality measure, okay? So I've been involved in creating a brief family survey, which is now used in star ratings. For a while, I was in the hospice star rating relocation program for my own safety. People were not happy with it. They thought for sure they were a 5-star hospice. So in that process, you have to go through this whole process of statistical review. And the linchpin in this review is usually something that's called inter-unit reliability. And what this is this saying group A is different from group B, okay? That we can say with statistical certainty that A is different from B, okay? And if you're not able to say that, CMS is very reluctant to say that measure can go up on the Compare website because their concern is they don't want to publish noise and they don't want to result in, hurting small providers with inaccurate information. Now, inter-unit reliability is about the signal, how big of an effect size there is, the sample size, and the measure and error of the noise, okay? I am not going to show you any formulas, so that's really good. This problem has really been highlighted in terms of CMS, in terms of special needs plans, okay? MedPAC, which I really love. How many people read MedPAC reports? I love reading MedPAC reports because MedPAC usually, I've gotten to know some of these people. They can be really angry and you can read between the line and you can hear what they're actually thinking. For the last 3 years, so Congress mandated MedPAC to report on the quality of special needs plans. And MedPAC has said back to Congress, none of the measures approved by CMS are reportable because of the concerns about the sample size of the denominator. And this has been sort of going an ongoing debate between these two entities right now, with CMS sort of doing what it usually does, is staying out of the fray until someone yells at them, and then they will do something. But, I think this is a real concern. There's about 4 million people who are duals, okay? For a typical MA program, it's a small population, okay? For a DSNP that's a special needs program, often they have small numbers and they're not publicly reported, okay? So now we have a group of people who've gone from fee-for-service, okay? where, you know, the error is over providing, care, providing care that someone did not want, to now a, where you make a profit by potentially not providing the needed care. Hopefully, they should make a profit by efficiencies, by better care coordination. But the real danger here, and what we've seen in the average population with denials, with phantom networks, with, copays, is not getting the needed care. So I see this as a real concern. So here's why these are concerns. This is a wonderful palliative care hospice physician, Nathan Gray, who really sort of illustrates how this can play out. Okay, I've been involved in hospice since my internship, which is a long time. And over the time, I've watched hospice change from a community-based organization to the majority of hospices are for-profits, and now a growing segment of the hospice industry are private equity, okay? And in these various firms, okay, we've seen a benefit that was created in the 80s. It was a very simple benefit structure. It basically paid you a per deed cost, and basically your profit was the difference of the cost of care per day. Nowhere in the regs, or what we call the condition of participation, is there anything that says you have to visit that person. Okay, it says you have to team the person every 15 days, and it says you're responsible, you're responsible for the quality of their care regarding that illness or the set of illnesses that results them in having an expected prognosis of 6 months or less. Okay, and so basically people will still get that paid, that per diem rate, even if they don't see someone in 2 weeks. Okay, and so as we saw this growth of for-profit providers, what we saw was alarming results, that various entities had profit margins that were high. Okay, visits were not occurring. And then what we publish is the brief family survey results that the quality of care in for-profit hospice programs compared to not-for-profit hospices were judged to be worse. Okay, now here, this is from a congressional testimony. Okay, so in this denominator problem, how you define a denominator can be a problem. So states license something called a CCN, a CMS certification number, okay? And some states take that responsibility different from other states. This is the state of California, and at this building, there's over 150 hospices licensed to this address. Okay, you can draw your own conclusions. So I think what's happened here is we've gone down this pathway where we've changed fundamentally how we're paying for medical care. We've flipped the incentives, okay? And in flipping those incentives, you are now putting a vulnerable population at risk, okay? And I think you all would agree with the various definitions of vulnerable population, that it's just not equality. It's about preventing and removing harm. It's about maximizing benefits over harm, okay? And I think we're failing in that now in our current quality measurement, okay? I think one of the things we need to do is when anytime we propose a measure, we have to say what the economic consequences of that measure is, what amount of money we're forcing them. But I think anytime we create an alternative payment model, I think we specifically have to have a plan in place for unintended consequences. The history is just too far that it's occurring. So in what we should learn from hospice is that we didn't anticipate the unintended consequences. And there have been not only really horrendous press stories. I talked to a lot of these reporters. For some reason, I'm on the frequent dial number, and they ask me about this. And the stories I hear are really horrendous. Okay, it's not the hospice that I started out with in the 90s. And I think our current safeguard, our quality measure for transparency has really failed. Okay, and part of the reason it's failed is we only measure quality of those people who die in hospice, but the live discharge rate for hospice in some hospices are running 50%. Okay, and that's really what the concern is. We have no measure for the prospective quality. So quality, we have problems with CCN assignment. The complaints process has not worked as well. State inspections have been problematic, and we have this status called deemed status where the hospice pays for someone to inspect them. May not work. MA, I think I've outlined what the problems are. And so inter-unit reliability is a huge thing, which I think we have to fix, okay? And the concerns with the inter-unit reliability is gaming the reportable unit. Go back to that, one building with 150 CCNs, surprisingly. Nobody from that address is publicly reported. I actually think probably many people from that address are not real bills, but 4 years later, and we still don't know. We have quality measurement, which is always based on a population average, okay? I'm the healthy person who's very glad to have their cataract surgery done, who takes 1 pill a day, and I see my doctor maybe once a year, okay? I don't know what you're going to get from me in a CAPS survey. But if you were to talk to a 79-year-old with multiple chronic conditions, you're going to get a lot of information because there's multiple contacts with the healthcare system and multiple areas for things to get screwed up. And therein lies the problem. The problem is the number. As long as we have these strict criteria around inter-unit reliability, we're not going to measure what's happening to vulnerable populations who are at risk the most from changing healthcare incentives. So how can we fix it? Well, first of all, we can do things to increase the denominator, okay? We can increase the strength of the signal. We can use a notion of decedents probabilities, which I'll explain to you. Second, we can address the denominator concerns. And third, we can improve communication regarding quality reporting. And I'll go through these a little bit quickly. We already borrow strength. We include more years of data, okay? And that allows us to publicly report on more hospice programs. So right now, we report on about 94% of hospice patients who die on the Medicare decedents. What we're missing is always those people who are live discharges, and I think that's a problem. Another thing we could do is called decedents probability. Today I saw there was a 100% chance of sunshine. And I think, every day people make decisions on the weather. Why can't we use this notion of probability and say, while this is not absolute certainty, here's the chance that this provider falls below this level. The other thing we can do is create bigger composites, okay? A composite is a collection of items. I think we can create an overall composite, but by making a bigger composite, you can increase signal strength, and you can report on more entities. The other thing is to do is worry about the 85-year-old, okay? Don't interview me. I don't think I need a CAP survey, but I may need a CAP survey when I'm 85 and frail and dealing with a dysfunctional healthcare system. I think the other thing we can do is educate consumers, okay? We're always assuming that people can't think, but I think we could provide them with the best data with the caveats and let them make a decision on that. We can also flag claims that, that suggest that the data is not accurate under the circumstance. So if you take a look at the collection of data for MA programs, A lot of it has to deal with the healthy 65-year-old, but some of it deals with people with chronic comorbid illnesses. And so one of the things we could do is we could allow people to know about how they do with what is your concern. So for example, Blue Cross Blue Shield in Rhode Island is 5 stars, but it only receives 3 stars for chronic care. So, you know, that would be a concern for me. And we're getting towards the end. I'm sorry I've gone over a little bit. This is my view of where we are right now. And with Sarah and Palin sending them, I think, you know, right now we've, you know, because we have not provided the oversight, we've not done a good enough job with the compare website. We haven't solved the denominator problem that we're letting insurance companies make decisions which are really explicitly about rationing care. We've not done well on certain survey. I think it was 7 years ago, I wrote a memo about targeting inspections based on quality data, and they're finally implementing it this year. So it's been really frustrating. I think at least once or twice a month, I get a letter about a complaint in a state that didn't go well. Most of them are below the Mason-Dixon line. Don't know what to do with that data, but it's a concern. And this comes back to where we are. I really think, you know, we're firmly committed going down to this value-based care. And I really think from the perspective of a moral test of a government is we need to fix the current system on how we're measuring quality of care. And we need to deal with, you know, the fact that by focusing in on the average healthy beneficiary, we're missing those who are at most risk of fraud and profiteering. Okay, I'll leave you with, this is the day I retired in France. I took that picture. And it was like, that was like one of the best days of my life. I said, I don't have to write another grant.
Thank you so much. Okay, we have time for maybe 1 or 2 questions.
Hey, I'm Nicole Cody, I'm a postdoc here.
Hey, Nicole.
I used to work at a HIV nonprofit as a social worker, and I signed up, I don't know, hundreds, but definitely dozens of people for Medicare Advantage plans who were people who needed low income, often had multiple high acute illnesses, but no chronic illnesses, need a lot of care. And I remember we were told to steer them towards MA plans for funding reasons, but I also felt like they were coming back with more what I was thinking was like administrative burden. Constantly have to deal with these private companies that were denying that, and like I felt like there were paperwork in their amount of work that they had to do as a result of moving them towards those plans was really stressful on them. And so I wonder if that's ever coming to your.
So I think one of the things as typically, the good news is that the essay I submitted only was 1,000 words. As you can see, I think I could write a whole paper. So one of the other suggestions I had that didn't make it in the paper is specifically to have a quality measure on the hassle factor. So for example, right now, you probably didn't know this. I didn't know this until last week, that there is actually a survey on disenrollment. And it's like not, and for some reason, there's a lot of data that's publicly available, but the disenrollment survey is not publicly available. And I think out of transparency, that should be top and center. Okay, so if I was a healthy 65-year-old choosing a Medicare Advantage plan, or if someone with HIV, I would want to know how much hassle I'm going to get, because how much time, because that would be like, I would probably pay a little more money to avoid that hassle, because it is a hassle. And I think what some of these MA programs do is they know that if they hassle you, there's a good percentage of people who will not fight it. And that's all profit margin for them.
Yeah, last question. Okay, and then we're just gonna curl up into the fetal position.
Then I'm a pediatrician, and we wrote a paper recently, well, not that recently anymore, but about the really small denominator of kids who are in these programs and are completely lost in the data.
Yeah,
So kids, they're often just stuck in these adult facilities or hospice places, both for long-term and for hospice care, and you can't disaggregate them at all, and I'm wondering if any of your
So-
work with this, you've got.
thank you very much for asking that question. Okay, for rare events, I don't think the survey quality measurement is probably the right answer. I actually think it's a situation where we need to rely on state inspections, okay? Right now, my sort of viewpoint on various state inspections is it's about name signatures and not really a lot about outcomes. And so I think we need to really be very transformative and targeted on the inspection survey. The other thing we're not doing a good job on is complaints, okay? I received, the last email I got that I responded to like 3 days ago was someone who works in the VA quality division whose father was dementia, up and walking on hospice, and went for respite care and got slammed with opiates and died. And this complaint's been going on for a year. And, you know, this is someone who wrote me 2 pages. And I can't believe that they haven't acted on that. I mean, I probably, if I was the hospice attendant, I probably would have reported it to the state, you know, in process as a suspicious death, as crossing the line. Yeah. You know, it's the levers we have. So I always look at sort of 3 big levers we have. Complaints is an important lever because I think the complaints are akin to an iceberg. What you see on top, to get someone to complain, underneath, there's probably a lot of iceberg. 2, surveys are really key. And I think for certain populations, I think hopefully the surveys that we mail out and to do via telephone, hopefully can be a helpful protection. Thanks. Sorry to move.